Hello, I'm Prochan Raman. I'm one of the associate editors at the Journal of Rheumatology. It's truly my pleasure today to welcome you to this interview with authors of a notable article featured in the July 2025 edition of the journal. Today, I have the honor of speaking with Drs. Koch and Cook, representing all the authors of our highlighted article, and that is the effect of early attainment of minimal disease activity on radiographic outcomes, a real-world longitudinal cohort study in psoriatic arthritis. So thank you both for joining us today to discuss the findings of your impactful research. Just to start with, if it's okay, can you provide some background and the rationale behind your study and just the major results that you are reporting?
Yeah, thank you for Dr. Rahman, and also thank you for us to give us this opportunity to talk about our current results about our studies. And yeah, maybe I'll start with the DAPAR cohort study, because DAPAR is a really good established real-world longitudinal cohort which contains the newly diagnosed psoriatic arthritis patients. And actually the real rationale about background about this article, this is the follow-up study of work within the DAPAR cohort. Yeah, we already defined the minimal disease activity within the first year after PsA diagnosis, and also we already show that this situation was strongly associated with the better long-term outcomes according to patient-reported outcomes, and including the improvements in pain, also fatigue, physical function, and mental well-being. And that is highlighted how early clinical control in the significantly improves the patient quality of life. But yeah, this study did not address the structural damage, and structural damage is a really key long-term outcome for the psoriatic arthritis. And also it is a very big question in the MDA research agenda, and that is why we designed this study by using our previous definitions. And in our study, we stratified patients into 3 groups: the MDA, sustained MDA group, non-sustained MDA group, and the no MDA group. Sustained MDA group contains the patient who achieved the MDA within the first year, at least at month 9 and 12. And no MDA group is contain the patients who did not achieve within the first year MDA. And also we have the 284 patients in our studies, and we focused mostly about the oligo and polyarticular psoriatic arthritis patients, because we use the radiographic progression data, modified total sharpened score, and which is the mostly assessed only peripheral joints. That is why we use only oligo and polyarthritic patients. And yeah, according to our results, we find nearly 40% of patients falling to MDA achievement within the first year. And at baseline, these patients, this no MDA group, had the higher proportion of women, and also they have the higher tender joint count again at baseline, and enthusiast counts, this no MDA group. And also they have the worst baseline patient-reported outcomes, which we already showed in our previous results. And also they also have a bit slightly higher modified total sharpened score at baseline. And when we assess as a longitudinal way over the radiographic changes over time, we use linear mixed model to find these solutions. And we found that who did not achieve MDA in the first year, which are the no MDA group, experienced significantly greater radiographic changes over the time than the other 2 groups, than the MDA achievement groups. And yeah, it is really this is really important outcome when we check it. Yeah, this is our main result. Yeah.
Thank you for that excellent. Sorry, go ahead, Marc. Sorry.
I think that for our colleagues in the Netherlands, at least, we try to make it a compelling message that the early effective control of PsAs, so it's not only possible but also crucial for protecting patients from permanent joint damage, in accordance to the other clinical and patient experience outcomes.
Great, thank you for that excellent summary. I'm just wondering, how did you account for the baseline risk factors of X-ray progression and some of the differences that you mentioned between the groups that had either sustained or MDA versus no MDA? Because they seem to be slightly different in terms of
Yes,
demographics.
I can say in my health as a numeric way, because of the median of the no MDA group is the baseline value is the 2 point, and the other one is only 0.9 or 0.7, but in the no MDA group, this rate is the 2.2 and more than 2. Yeah.
Okay. So what led you to choose MDA? So we all realize the benefit of MDA, and sometimes we're not doing it in practice. Why the MDA as compared to just the swollen or tender joints, which is sometimes more ubiquitously done by physicians?
Yeah, thank you so much again, your questions. Yeah, it is. Yeah, you are right. It is not so handy for the daily clinical practice because it's really strict and includes lots of components. But also we know the PsA is really heterogeneous disease, and MDA takes into account all this heterogeneity of the PsA because it's not assess only peripheral joints, but also assess skin, enthesitis, also axial symptoms, and also patient-reported burden like patient pain and function. It's really captured scores. That is why we use, because also, yeah, again, the PsA is really heterogeneous and it is not easy to find only checking for the swollen joint count to associate with the long-term outcomes. That is why we choose the MDA. It's really holistic approach for the disease activity assessment. Yeah.
Yeah, but we totally agree that in clinical practice it's it's difficult to routinely measure. So in that respect, we have a collaboration with our colleagues from the UK, especially William Tillett, to see if there are other easily done measures. And so we are now looking into and investigated and already published. That was Fazira Kazim in 2023. Another composite score, the 3-VAS and the 4-VAS, to be more, easily done in routine clinical practice. So I think, yeah, that's an important addition and observation that it's difficult in clinical practice, routine clinical practice, to assess MDA at every patient.
That's very interesting. Thank you. So you had an early PsA cohort, I think the symptom duration being anywhere between 7 to 13 months. Do you think it's easier to achieve MDA in this cohort? Only a third of your patients didn't achieve it. And also just wondering how sustainable was that MDA beyond 1 year in terms of 2 or 3 years, because you looked at the outcome at 3 years.
Yeah, thanks again for your really good points. And yeah, it is not easy to answer. I think especially the third part. Yes, our cohort is an early cohort. It is the median of the symptom duration is 7 months. And yeah, but yeah, it's all we know, the achieving MDA is generally more feasible. More feasible in the early PsA. We already showed the other cohort, and due to lower baseline disease burden, shorter symptom durations. And yeah, of course, our data show that a third of patients achieve sustained MDA, and looks like in our cohort have with the early cohort, the patients has come with more milder than the normal established PsA cohorts. Of course, that helps to achieve the MDA a bit easier than the other cohorts, but it's only speculations. It's not easy to say, yes, it is easier or it is harder than the others. But of course, it may help to achieve a bit easier achieve the MDA than the other cohorts. Yeah, I think so. That because the baseline swollen joint or the baseline disease activity is more milder than the other established cohorts. Yeah.
Yeah, to add to that, it's in the Netherlands, it's historically the awareness under GPs is very high for arthritic disease. We have had multiple campaigns, especially for rheumatoid arthritis, to train the GPs to early recognize arthritis, and I think that's one of the reasons it's paying off, that the relatively low symptom duration at baseline, because that's reality in the Netherlands, and I think we realize it's not everywhere the same, but that's I think also an explanation.
Great, thank you. I'm just wondering if you were to achieve radiographic outcome in the absence of biologic use, would you expect a similar inhibition in terms of radiographic inhibition? In other words, how much did the presence of biologics play into improvement in terms of long-term radiographic inhibition?
Yes, actually, yeah, according to already we know in the current literature, we know the most radiographic, most biological helps to stop or slow the radiographic progression during the follow-up. It is a very well-known knowledge. Yeah, of course, it's helpful, but when we are looking at our data, when we are looking for our results, we solved at the baseline table because we already checked. Also, we use as a covariate biological use during the follow-up. And no MDA group has the highest biological use than the other one. And no MDA group had the lowest biological use. But on the other hand, it is not a causal relationship between the radiographic data. I think it's about to, because also we are already, is a really hot topic, is the difficult to treat things. I think this no MDA group also is kind of the poor prognostic factor for the psoriatic arthritis. That is why this group also poor prognostic of the difficult to treat, because they need more biological use. And of course, the sustained MDA group have the lowest biological use, because also this group also good prognostic factor has, because this is not suggesting these patients had milder disease, had better response to conventional DMARD, had better prognostic factors. Yeah, according to our results, it's a bit different, but it is not associated with the biological use. I think it's about the prognostical factor for the MDA. But of course, in the literature, it's very well known the biologic is slow to radiographic progression or radiographic changes during the follow-up.
Yeah, and Proton, I think that these results and the question and then the discussion about treat to target, I think the answer of Hazal is basically in line, I think, with the data that the Tchetverikov trials showed, right? With the regards to 48-week follow-up, I think that there was no significant difference in the groups between radiographic damage.
Great, thank you. So a similar analysis was done in terms of the Goekoop-Ruiterman study, where they looked at what they described as sustained MDA for them and better radiographic outcomes. So your study was a real-world study. What do you think of the advantages of real-world versus the sub-study from the clinical trial?
Yeah, it's again a good one. Of course, the randomized control trial is really important, and also it is because they are designed for only to show something really good without co-founders or covariate factor. But yeah, for using the randomized control, using the cohorts like the real world cohort like us, because as I mentioned before, yeah, PsA is really heterogeneous disease, and also the real life, there's a lot of heterogeneous patient populations. And of course, kind of questions conducting with the real world cohort, adding the heterogeneity to show that how is going on with the daily life, because we are not using always as a first time biologic. We are not, also the patients has some problem. So yeah, it's important to showing the heterogeneity of the data and how it's going with the real life. So yeah, that is why important conducting these questions with a real world cohort. So then the randomized control trial.
Great, thank you. I was just once surprised just with one aspect of your results, and that was the skin status was associated with radiographic outcome. I was just wondering why you think that is the case.
Yeah.
Yeah, it's a very interesting question, but so I think, to be honest, we saw the association, but we can, as of course, then also in regards with the previous question, it's difficult to establish a causal relationship, right? In real world cohort studies. I don't know. We could speculate between the relationship of the skin and the joint. And we had another PhD student, Anna De Braker, who looked into the relationship between the skin and the joint and the role of the lymphatics. But to be honest, Proton, I don't know. I'm open for any suggestion to do further research in that direction, because it's an observation, but I don't know what's happening there.
Okay, great. Thank you. So is there anything else you'd like to add that I might have overlooked that you think is important in terms of this discussion for our readers regarding either the value of your study or anything else, any other insights that came from this?
I think for us and for our colleagues in the Netherlands, because I think and that's the same in every country, right? We have to educate our colleagues in many aspects, and what we see is that in the field of or in the treatment of PsA within the Netherlands, it's still not widely practice that we treat the disease early on and relatively, although that's what the colleagues respond to, aggressively, right? Like in concordance with the guidelines, stating like, don't waste too much time and just start early intensive treatment, use a biologic. And I think this underscores again that important, the vital message for the patients living with PsA to really treat earlier and suited, because we prevent also structural damage by preventing early. And
Is there
that's at
also
least, yeah.
Sorry to interrupt.
No.
Is there's also a move towards treat to target then within Netherlands?
It's a very interesting question, and like we discussed before, we just finished the STEM trial. Actually, Hazal did, so maybe she can say a few words about that, and which is.
Yeah, for the treat to target. Yeah, of course, in the we already also finished the treat to as a treat to target. Also, our target is the MDA in that study in STEM. But for still after our results, we still don't know what is the long-term outcomes, especially in the radiographic data. But when we check for the relative short-term outcomes in the first 1 year, this group has the rapid and faster clinical outcomes, of course. And also I have the chance to check for this data with our normal cohort data, and it looks like when we check for the Tchetverikov normal group, the treat to target group has really better outcomes than to reach the MDA or remission or low remission, and also the other important disease activity achievement better than the normal cohort. The effectiveness is really better. But I think the most important part to seeing the really cost effectiveness things, to seeing the long-term outcomes. For example, the structural damage is really important. It's really effective on the radiographic data. It's really effective on the other long-term disease activity scores. But for now, it has a really effective for the relatively short long-term.
Yeah.
Oh, great.
So we believe that it is for treat to target is a good
of course
a good principle, and the discussion remains a little bit what's the real good target and is feasible in clinical practice day by day, right? I don't know, but I think that's the struggle from every rheumatologist in practice, I think.
So thank you so much for taking the time to share your insights on this very important and intriguing article on the early achievement of MDA and its implication in terms of long-term radiographic outcome. So just to our audience, I encourage you to read the article titled "The Effect of Early Attainment of Minimal Disease Activity on Radiographic Outcomes, a Real-World Longitudinal Cohort Study in PsA." And that's going to be available in the journal's website at jroom.org in the July 2025 edition. And thank you for joining us today. We hope you'll tune in next month when we discuss another article of particular interest from the next edition of the Journal of Rheumatology. We welcome all comments on X at JRoom or via email at manuscripts@jroom.com. I look forward to the next encounter. Thank you and goodbye for now.